Wide complex tachycardia, WCT, ECG differentiation. Wide QRS complex tachycardia, WCT, may result from a. Rhythms in which ventricular activation starts outside the His-Purkinje system. 1. Ventricular tachycardia, VT. 2. Pre-excited supraventricular rhythms. b. Supraventricular rhythms conducting in the AV node, then aberrantly in the ventricles, due either to 1. Rate-dependent aberration, or 2. Pre-existing bundle branch block, BBB. In this way, patients with WCT can be classified into two groups, Group 1 including VT and pre-excited supraventricular rhythms, in both ventricular activation starts outside the His-Purkinje system, and Group 2 including supraventricular tachyarrhythmia with either rate-dependent aberration or pre-existing BBB, in which the impulse conducts in the AV node followed by abnormal intraventricular conduction. To avoid inappropriate therapy, the unknown rhythm should be presumed to be ventricular tachycardia, VT, until proved otherwise, because the diagnosis of WCT cannot always be made from ECG with complete certainty, and VT accounts for up to 80% of cases of WCT in adults. When the diagnosis is uncertain, intravenous drugs, verapamil, adenosine, or beta blockers, should not be used for the treatment of supraventricular tachycardia, SVT, because they can result in severe hemodynamic deterioration in patients with VT and can even provoke cardiac arrest. For the differential diagnosis of WCT, the following surface ECG characteristics must be studied. 1. Atrioventricular, AV, and ventriculotrial, VA, dissociation or association. 2. Analysis of the QRS complex and the STT waves. 3. Characteristic QRS morphology. 4. Characteristic ECG patterns. Differentiation with QRS morphology is the most accurate. Other criteria, however, may also be necessary, including 1. Clinical findings. 2. Comparison of the ECG during tachycardia with an ECG during sinus rhythm if available. 3. Analysis of the ECG for AV dissociation or association. 4. Analysis of the ECG for capture beats and fusion beats. 5. Analysis of the ECG for concordant positive or negative QRS complexes in all chest leads. 6. Observation of the presence of polymorphic tachyarrhythmia. 7. Measurement of the QRS duration. 8. Identification of the frontal plane QRS axis. QRS morphology. As a rule, if the WCT is caused by supraventricular tachyarrhythmia with aberration or pre-existing BBB, then the QRS during the WCT must be compatible with some form of BBB or a combination of BBB and fascicular blocks. If this is not the case, then the diagnosis by default is VT, or much less commonly, pre-excited SVT. The best differentiation between Group 1, VT and pre-excitation, and Group 2, rate-dependent and pre-existing BBB, is obtained by careful analysis of the wide QRS configuration. Atypical right or left bundle branch block patterns strongly favor Group 1. Typical patterns of right or left bundle branch block are almost always diagnostic of Group 2. Typical right BBB pattern is mainly identified by 1. RSR', with R' taller than R, in lead V1. 2. Tall R with deep wide S in lead V6. Atypical right BBB patterns include in V1, RR', with R taller than R', or monophasic R, or QR pattern, and, or, in V6, small r deep S, Rs, or QS, R wave is absent, or monophasic R, S wave is absent. Typical left BBB pattern is mainly identified by small r with deep S in V1, and tall wide R in V6. Atypical left BBB patterns include in V1, marked widening of QRS with any of the following: R wave duration greater than 30 millisecond. Interval from the start of R to the nadir of S greater than 60 millisecond. Or the presence of a notch on the downstroke of S wave. N/or. In V6, the presence of any Q wave, whether QR or QS complex. Typical left BBB pattern is not always diagnostic. The presence of typical left BBB pattern during tachycardia mostly diagnoses SVT with aberration or pre-existing BBB, with two exceptions, in which tachycardia is conducted via the normal His-Purkinje system. Bundle branch reentry VT, with anterograde conduction over the right bundle branch. Pre-excited SVT utilizing an atriofascicular bypass tract, with anterograde conduction over the right bundle branch. In bundle branch reentry VT, when anterograde conduction occurs over the right bundle branch, typical left BBB pattern is seen. On the other hand, when anterograde conduction occurs over the left bundle branch, typical right BBB pattern is seen. The patterns are typical, despite being VT, because ventricular activation starts in the His-Purkinje system. Bundle branch reentry VT is a monomorphic VT. It is a self-limited phenomenon in patients with normal intraventricular conduction, since the rapid conduction and long refractory period of the His-Purkinje system prevent sustained bundle branch reentry in normal hearts. Bundle branch reentry, BBR, may, however, be sustained by dilated heart, with longer reentrant pathway and longer conduction time. His-Purkinje system disease, with slow conduction. Heart diseases associated with bundle branch reentry VT. Dilated cardiomyopathy, 45% of cases. Other causes include cardiomyopathy secondary to valvular heart disease or ischemic heart disease, hypertrophic cardiomyopathy, and Ebstein's anomaly. Pre-excited SVT utilizing an atriofascicular bypass tract, like bundle branch reentry VT, when anterograde conduction in these patients proceeds in the right bundle branch, there is typical left BBB pattern, but when anterograde conduction proceeds in the left bundle branch, there is typical right BBB pattern. From the previous discussion, it follows that typical right BBB pattern also is not always diagnostic. Although the presence of typical right BBB pattern during tachycardia mostly diagnoses SVT with aberration or pre-existing BBB, there are three exceptions. 1. Left ventricular fascicular VT. 2. Very rare cases of bundle branch reentry VT with anterograde conduction over the left bundle branch. 3. Pre-excited SVT utilizing an atriofascicular bypass tract, with anterograde conduction over the left bundle branch. Algorithms. Many algorithms have been developed to help distinguish the group of VT and pre-excitation from that of SVT with rate-dependent aberration or pre-existing BBB. We would like, however, to emphasize that neither the details of QRS morphology just discussed, nor the algorithms to be discussed here, can diagnose with certainty all cases of WCT. Unfortunately, despite their difficulty, all these details should be kept in mind in our clinical practice. They are complementary and very helpful. If still in doubt, one must proceed for electrophysiological studies, because accurate diagnosis is essential for appropriate treatment. Brugada algorithm for the differentiation between Group 1 and Group 2. Proceed sequentially in the following order. Step 1. Look for absence of an Rs complex in all chest leads, then the diagnosis is Group 1, VT or pre-excitation, if not. Step 2. Onset of R wave to nadir of S wave greater than 100 millisecond in at least one precordial lead, the diagnosis is Group 1, if not. Step 3. AV dissociation present, the diagnosis is Group 1, if not. Step 4. Morphological criteria of VT present, the diagnosis is Group 1, if not, then the final diagnosis is Group 2, SVT with either rate-dependent aberration or pre-existing BBB. This diagram shows how to measure the interval from the start of R wave to the nadir of S wave. Morphological criteria of VT described, in Brugada algorithm, are the same QRS morphologies described before for atypical right or left BBB patterns. AVR algorithm 1, Veracay criteria. This algorithm depends on the analysis of the QRS morphology in lead AVR alone. It proceeds sequentially in 4 steps. Step 1. Initial tall R in AVR indicates VT or pre-excitation, if not. Step 2. Initial R or Q duration in AVR greater than 40 ms indicates VT or pre-excitation, if not. Step 3. Notch on the downstroke of a negative onset predominantly negative AVR indicates VT or pre-excitation, if not. Step 4. Ratio of the vertical vector of the initial 40 ms to that of the terminal 40 ms, VI to VT ratio, equals 1 or less indicates VT or pre-excitation, if not, SVT with aberration or BBB is diagnosed. This figure explains how to measure the VI and VT used in step 4, whether the QRS is positive or negative. To measure VI, begin at the start of QRS and move for 40 ms forward, then measure the vertical distance between the point of transection with the QRS at 40 ms and the vertically farthest point of the QRS during these 40 ms. To identify the VT, do the same thing but begin at the end of QRS and move for 40 ms backward. AVR algorithm 2. This algorithm also depends on the analysis of the QRS morphology in lead AVR alone, and proceeds sequentially in 4 steps. Step 1. AV dissociation present, diagnose VT or pre-excitation. If not. Step 2. This is the same step 1 in AVR algorithm 1. If not. Step 3. Atypical BBB pattern, diagnose VT or pre-excitation. If not. Step 4. This is the same step 4 in AVR algorithm 1. Accuracy of algorithms. AVR algorithm 1, about 92%. AVR algorithm 2, about 90%. Brugada algorithm, about 85%. Now, if you diagnose your patient in group 1, VT or pre-excitation, you still need to differentiate between them. Differentiation between VT and pre-excitation is particularly difficult, because ventricular activation begins outside the normal conduction system in both conditions. Other factors, such as older age and past history of myocardial infarction, may suggest VT, particularly because pre-excitation is an uncommon cause of WCT. Brugada algorithm for differentiation between VT and pre-excitation. Each of the following 3 criteria is 100% specific for VT, no false positive results, otherwise pre-excitation is diagnosed. 1. Predominantly negative QRS in V4 to V6, in pre-excitation, conduction proceeds from the base toward the apex and should result in predominantly positive QRS in V4 to V6. 2. QR complex in one or more of leads V2 to V6. 3. More QRS complexes than P waves. Finally, when you diagnose VT, you still need to identify its site of origin. ECG localization of the VT site of origin. 1. Lateral, inferior or anterior. 2. Left ventricular or right ventricular. 3. Apical or basal. 4. Epicardial or endocardial. Lateral, inferior or anterior. Step 1. Lateral leads, lead 1, AVL, and V6. Dominantly negative QRS, lateral focus. Dominantly positive QRS, go to step 2. Step 2. Inferior leads, lead 3 and AVF. Dominantly negative QRS, inferior focus. Dominantly positive QRS, anterior focus. Left ventricular or right ventricular focus. Examine chest leads, V1 to V6. Right BBB-like pattern, left ventricular focus. Left BBB-like pattern, right ventricular focus, or septal focus. Apical or basal. Examine chest leads, V1 to V6. Dominantly negative QRS, apical focus. Dominantly positive QRS, basal focus. Epicardial or endocardial. Slurred initial QRS deflection, epicardial focus. No slurring in initial QRS deflection, endocardial focus. Other criteria. Besides the previously discussed QRS morphologies and algorithms, other criteria may also be necessary, because all described details cannot diagnose all cases of WCT with complete accuracy. Other criteria include the following. 1. Clinical findings. 2. Compare the ECG during tachycardia with an ECG during sinus rhythm, if available. 3. Analyze the ECG for AV dissociation or association. 4. Analyze the ECG for capture beats and fusion beats. 5. Analyze the ECG for concordant positive or negative QRS complexes in all chest leads. 6. Identify if the tachyarrhythmia is polymorphic. 7. Measure the QRS duration. 8. Identify the frontal plane QRS axis. 1. Clinical findings, play the odds. 80% of WCT in adults is VT. In presence of old myocardial infarction or other structural heart disease, it is 95% VT. 2. Compare the ECG during tachycardia with an ECG during sinus rhythm, if available. If pre-excitation is present during sinus rhythm, pre-excited tachycardia is favored. If bundle branch block is present during sinus rhythm like that during tachycardia, SVT with pre-existing BBB is favored. If bundle branch block is present during sinus rhythm, but different from that during tachycardia, that is, right BBB in sinus rhythm but left BBB in tachycardia, or vice versa, VT is diagnosed. 3. Look for atrioventricular, AV, and ventriculotrial, VA, dissociation or association. AV or VA dissociation means that there are two foci, one pacing the atria and the other pacing the ventricles. Association means that both atria and ventricles are paced by one and the same focus. Dissociation is diagnostic of VT, except rarely. Dissociation, however, is present only in about half of the cases of VT, while in the other half, VA association is present, because the VT focus itself controls the atria as well, through regular VA conduction, which could be in the form of 1-to-1 or 2-to-1 conduction, or in the form of Wenckebach retrograde VA block. Another problem is that dissociation, when present, is difficult to detect. VT with VA association. AV, VA association, does not exclude VT, because VT itself may control the atria, through 1-to-1 VA conduction, in 30% of cases of VT. Or second-degree VA conduction, in 15% of cases of VT, for example, 2-to-1 or Wenckebach block. Here is a diagram showing VT with retrograde 1-to-1 VA conduction, and VA association. Each QRS is followed by a retrograde P wave, arrow. In this schematic, VA association is present in VT, due to regular VA conduction with Wenckebach block. Beat 1 is followed by the shortest VA conduction time, after beat 2 VA interval is longer, which still gets even longer after beat 3, then beat 4 is blocked, with no conduction to the atria, and the cycle repeats, typical of the Wenckebach type block, but in the retrograde ventriculotrial, VA direction. In VT with type 1 second degree, Wenckebach, retrograde, VA, block, all the 5 features of classic Wenckebach behavior can be demonstrated. 1. Decremental conduction, that is, gradual prolongation of VA conduction time. 2. Group beating. 3. Separated by pauses. 4. The pause is less than the sum of 2 pp cycles, and 5. The VA time post-pause is shorter than the VA time pre-pause. It is to be noted, however, that the pauses in this retrograde fashion are pp pauses, not the QRS pauses known in anterograde atrioventricular, AV, Wenckebach behavior. Although dissociation is almost diagnostic of VT, yet there are 2 very rare conditions of wide complex SVT with AV dissociation. 1. Atrioventricular nodal reentrant tachycardia, AVNRT, with aberration, and block of retrograde conduction to the atria. In this case, the atria are controlled by the sinus node, while the ventricles are controlled by AVNRT. 2. Atrioventricular reentrant tachycardia, AVRT, utilizing a notoventricular bypass tract, with block of retrograde conduction to the atria. In this case, the atria are controlled by the sinus node, while the ventricles are controlled by AVRT. In this schematic, 1. AVNRT with aberrant conduction to the ventricles, WCT, and retrograde block to the atria, causing AV dissociation. 2. AVRT utilizing a notoventricular bypass tract, with retrograde block to the atria, also creating WCT with AV dissociation. Diagnosis of dissociation. The following ECG findings help establish the presence of dissociation. 1. Dissociated P waves. 2. Fusion beats. 3. Capture beats. Dissociated P waves. When the P waves can be clearly seen and the atrial rate is unrelated to the ventricular rate, AV dissociation is present. AV dissociation with an atrial rate slower than the ventricular rate occurs mostly in VT, but also in the two rare exceptions just mentioned, AVNRT with aberration and block of retrograde conduction to the atria, and AVRT utilizing a notoventricular bypass tract with block of retrograde conduction to the atria. AV dissociation with an atrial rate faster than the ventricular rate is seen in SVT having AV conduction block. 4. Fusion and capture beats. Ventricular fusion occurs when a ventricular and a supraventricular focus simultaneously activate the ventricular myocardium. The QRS has an intermediate morphology between sinus QRS and pure ventricular QRS. Fusion during a wide complex tachycardia occurs in two conditions. 1. VT, in which fusion occurs between the VT impulse and a supraventricular impulse. 2. Rarely, in SVT with aberration, when an incidental PVC fuses with the SVT impulse. Fusion beats during WCT are, therefore, diagnostic of AV dissociation, and almost, but not always, diagnostic of VT. Capture, Dressler, beats. A Dressler beat is a normal QRS identical to the sinus QRS, occurring during the VT. The term capture indicates that the normal conduction system has captured control of ventricular activation from the VT focus. Capture beats during WCT are therefore diagnostic of both AV dissociation and VT. Fusion and capture beats are more commonly seen when the tachycardia rate is relatively slower. Fusion and capture beats do not alter the rate of the VT. However, a change in the preceding and subsequent RR intervals may occur. In this schematic, sustained monomorphic VT with capture beats, C, and fusion beats, F, is shown. 5. Positive or negative concordance of QRS complexes in all chest leads is strongly supportive of VT diagnosis. In this figure, the QRS complexes are positive in all chest leads. And here is negative concordance of QRS complexes in all chest leads. 6. Polymorphic tachycardias, as seen in this figure, are almost exclusively VT. Rarely pre-excited atrial fibrillation in patients who have multiple bypass tracts may present similarly. 7. QRS width. QRS width during WCT with right BBB pattern greater than 140 ms is strongly in favor of VT. QRS width during WCT with left BBB pattern greater than 160 ms is strongly in favor of VT. 8. Frontal plane QRS axis. The following are strongly in favor of VT. 1. WCT with northwest QRS axis, that is, an axis in the right upper quadrant between -90 and -180 degrees. 2. WCT with left axis deviation beyond -30 degrees. 3. WCT with left BBB-like pattern associated with right axis deviation. ECG pattern recognition. 3 characteristic ECG patterns should be kept in mind. 1. Right ventricular outflow tract VT. 2. Left ventricular fascicular VT. 3. Bidirectional VT, discussed earlier. Right ventricular outflow tract VT. In WCT with left BBB-like pattern, right ventricular outflow tract tachycardia should be considered. This form of VT arises from the highest part of the heart, and spreads downwards towards the inferior ECG leads, 2, 3, and AVF, and away from both AVR and AVL. It is characterized by 1. Left BBB-like pattern. 2. Very tall R waves in inferior leads. 3. Predominantly negative QRS complexes in both AVR and AVL. Left ventricular fascicular VT. In WCT with right BBB-like pattern, left ventricular fascicular VT should be considered. This form of reentry VT originates more commonly in the left posterior fascicle, and less commonly in the left anterior fascicle. In left posterior fascicular VT, the exit site to the ventricle is inferoposterior, the impulse travels retrograde in the left posterior fascicle, then anterograde in the left anterior fascicle, then exits to the myocardium, and so on. In left anterior fascicular VT, the exit site to the ventricle is anterosuperior, the impulse travels retrograde in the left anterior fascicle, then anterograde in the left posterior fascicle, then exits to the myocardium, and so on. It follows that fascicular VT is characterized by the following ECG features. Left posterior fascicular VT. Right BBB-like pattern with left axis deviation, the impulse travels from inferoposterior to anterosuperior. Left anterior fascicular VT. Right BBB-like pattern with right axis deviation, the impulse travels from anterosuperior to inferoposterior. If these three characteristic VT patterns, right ventricular outflow tract VT, left ventricular fascicular VT, and bidirectional VT, are excluded, then proceed for differential diagnosis, utilizing all the details of QRS morphology, algorithms, and other criteria outlined in this lecture. Thank you.